everybody, and welcome. Thank you for tuning into Stroke Busters, a podcast presented by the Institute for Stroke and Cerebrovascular Diseases at UTHealth Houston in Houston, Texas. The purpose of this podcast is to bring you the latest news and discussion in stroke care, research, community, and academia. I'm Amy Quinn, Communications Director for the Stroke Institute. On today's episode, we have the extreme pleasure of welcoming Dr. Wondwossen Tekle following his Vascular Neurology Grand Rounds presentation at McGovern Medical School. He spoke on his experience establishing the first Stroke and Neurointerventional Program in Ethiopia. UTHealth Houston Vascular Neurology Fellow Carlos de la Garza dove into his story further for this episode. So let's get right to it. Enjoy.
Thank you for joining us for Stroke Busters. My name is Carlos, and today we are joined by Dr. Tekle, who just presented on establishing the first Stroke and Neurointerventional Program in Ethiopia for the McGovern Medical School Vascular Neurology Grand Rounds. He graciously agreed to stick around and recap the topic for you, our listeners. He is a triple board certified physician and associate professor of neurology and neurointerventional surgery at the University of Texas, Rio Grande Valley. He is board certified in neurology and vascular neurology by the American Academy of Neurology and CAS certified in neurovascular surgery by the American Society of Neurological Surgeons. He completed his medical school in the year 2000 at the Addis Ababa University School of Medicine, later moved to the United States and completed his medicine internship at Howard University and neurology residency at George Washington University in Washington, D.C. Subsequently, he completed his ACGME accredited fellowship, University of Minnesota in vascular neurology and neurocritical care and endovascular surgical neuroradiology. He also completed a clinical research training at Harvard Medical School. He has co-authored multiple peer-reviewed publications and book chapters in stroke and cerebrovascular disease and neurocritical care. He serves as reviewer for multiple neurologic medical journals. He is also a senior member of the American Academy of Neurology, Society of Vascular and Interventional Neurology, American Society of Interventional Pain Physicians, and Society of Neurointerventional Surgery. About 2 years ago, he moved most of his clinical practice from Texas to Addis Ababa, Ethiopia, after establishing Axon Stroke and Spine Center, the first comprehensive stroke center in Ethiopia. Dr. Wondwossen is the CEO and medical director of the Axon Stroke and Spine Center and Ethiopian Stroke Initiative. And we have the pleasure of having him talk to us regarding establishing the first stroke and neurointerventional program in Ethiopia. Dr. Tekle, please.
Thank you so much, Carlos. That was a very kind introduction. Thanks again, Sunil, and all of you, the organizers, for inviting me to share with you my experience, my Ethiopian experience.
Dr. Tekle, I'd like to start off by mentioning that you, along with Dr. Hassan, built up the endovascular and stroke program down in the Rio Grande Valley, which filled the region with exceptional care over the past couple of years. This is especially interesting and special to me because it's a place where I grew up and a place we both know is notoriously underserved. And I think we can draw some similarities between building up said program and starting one in Ethiopia, given both places have a population with lower health literacy, higher prevalence of comorbidities, and overall low socioeconomic status.
Yes, thank you, Carlos. Thank you for having me. Thank you for the opportunity to discuss my Ethiopian experience with you and with your listeners. Yeah, it's such a pleasure to speak with you, especially because you are from the Valley. And you know, the Valley, Harlingen, McAllen, Brownsville has been home to us for nearly 10 years now, going into 11 years. I still practice in South Texas. As you know, I do come back and forth every 2 months to practice in South Texas. Yeah, so like you said, you know, there are a lot of parallels, with patients in Ethiopia and in South Texas. Low literacy rate, education, level of education and awareness, and a lot of comorbidities. And as I said earlier, Ethiopia is a huge country, number 2 in Africa and number 12 in the world in terms of population, 120 million people, because it's a third world or country, or a developing country. It has a lot of needs, so a lot of people do not have those needs met, which means, quality food, quality healthcare, preventive healthcare services, acute reperfusion treatments, or rehabilitation services are not readily available. So the prevalence of this vascular risk factors are high. Prevalence of hypertension, at least based on some old data. As you know, there's a problem with data, in the third world countries. Based on old data, is up to 25%. Even in places, like the United Nations, there's multiple surveys done to check the prevalence of hypertension. It can be as high as 17 to 20%, even among people who have access to healthcare, relatively more educated, and so on. So yes, there is definite parallels between Ethiopia and South Texas. So what do we do? We do what I do here is what I did in South Texas. We go around and engage different stakeholders, hospitals, healthcare centers and institutions. We give talks and in different conferences in community centers and schools. So these are important, as you know, to create awareness and to build a program as well. We work with industry in the same way we did work in South Texas to try to enhance, push them to increase their presence in Ethiopia, which is very difficult to have, both medications and devices in Ethiopia nowadays, because there's nothing going on and it doesn't make business sense for them to be available widely. And also we do a lot of advocacy, with the government. We speak with the Minister of Health and all sorts of departments to try to create some sort of advocacy, especially when it comes to acute stroke reperfusion therapy. So yeah, we approach it the same way we did approach it in South Texas, basically trying to create awareness through all sorts of channels that we can get, print media, and TVs, ads, and again, going around shaking hands and so on and so forth. So we're doing our
And I
best to
think
find the parallels.
you beat me to the punch there, because that was gonna be my first question. We're not as big as Ethiopia in the Valley, but I mean, we, as you well said, and as we've been mentioning a couple of times, the similarities are there's a lot of similarities between both our populations. But yeah, you already mentioned kind of what you took from the Valley and implemented in Ethiopia, specifically all the I guess legal part of setting up a program over on your side. So I'll just go ahead and move on. What do you think is the main hurdle that you've been faced or are currently facing regarding just run-of-the-mill stroke or endovascular care?
Mhm. Yes, so hurdles, I mean, there are a lot of hurdles, no questions about it, because there are no, the stroke system of care is not well developed. We don't have, set guidelines yet developed locally. We're using, obviously, guidelines developed in the West and so on. But as you know, we need guidelines also tweaked based on local experiences and local data, because some things need to be tweaked, to work best in this locality. A lot of issues or deficiencies in trained manpower, as I was describing or showing you in my lecture. Fellowship trained stroke neurologists are not here, are not present currently. We are training four of them as we speak. So in terms of trained manpower, in terms of protocols and guidelines, these are lacking, and we're working with the government, with the public sector to try to develop this. Health policy itself is prohibitive right now. It's crazy that this third world countries, and you're already poor and you have limited resources and you haven't even overcome the basic things like communicable diseases. Now you're being hit with non-communicable diseases, which is, among which is a stroke, and cardiovascular diseases take a significant proportion, approximately 25%, at least in Ethiopia. Now, these have become the non-communicable diseases, stroke and cardiovascular diseases have become the number one killers of adults in Ethiopia. In Ethiopia, but resource allocations are still lopsided towards communicable diseases, because the meager resources are, that they have, they're not able to distribute them among all sorts of conditions, because the quadruple burden of diseases in third world countries is too much for the economies to handle, right? I mean, there is communicable diseases still, we haven't overcome them. Non-communicable diseases, there's injuries and childcare and maternal health issues. All of these need attention, and because of this, when you look at health policy and cost effectiveness analysis, stroke and cardiovascular care is supposedly the least cost effective for countries like Ethiopia. And these kinds of health policies are obviously very difficult, and they make your life difficult when you try to create or establish centers like this. And again, supply chain issues are very, very significant. I mean, it's very difficult to find drugs sometimes, and devices that you need urgently. They're expensive. Foreign currency may not be available through the banks to trade, to make those trades. And device companies are not here the way we want them, at least for me, who train in the US, who are used to luxury. We don't have them even to a lower extent, and they are looking for for the money, for the business, right? As more and more centers create, of course they will be incentivized to come, but right now it's very difficult to find devices and medications also. So all this are some of the main hurdles that I have.
Of course. I mean, and it makes sense. I mean, setting up a program from zero, it's quite difficult,
Yes.
as you've well shown us. But how has the majority of the populace, how have the majority of the physicians reacted to this new technology that you're basically bringing for the first time over to Ethiopia?
Oh, they're excited. Every year you go and you give talks, and I gave talks, a while ago on the National Radiology Society annual conference, and they're amazed what can be done nowadays. Honestly, when I was in med school and I graduated medical school 20 years ago, 22 years ago to be exact, back then, we did nothing. We offered nothing basically for stroke patients. You have an LVO or large vessel occlusion stroke, what can we do for you except maybe giving you aspirin? Aspirin has its benefit, but a vast majority of these patients could die. So that's the mentality that everybody is in. And what we could do, what we've been able to achieve with stroke care over the last 2-3 decades is honestly mind-blowing. I mean, looking at good outcome rates anywhere between 50 to 70% of what could be a catastrophic illness, such as an LVO stroke, is really mind-blowing. So they are accepting it, they are excited about it. The only issue, or the major issue, or everybody asks you, how about the cost? What do we do with the cost? A vast majority of our patients cannot afford this. These are some of the issues that they have, but they're very excited.
Absolutely. And that makes a lot of sense. I mean, cost is always one of the main drivers in healthcare, unfortunately. Getting into the technical aspects of stroke and stroke care, have you noticed any difference in mechanism of stroke over in Ethiopia, say more intracranial athero or perhaps more AFib or something like that?
Yes, that's a good question. As far as mechanism of stroke, there pretty similar, except that in Ethiopia or in the third world setting, one thing that we don't commonly see in the US, for example, valvular heart disease from rheumatic heart disease. Kids get pharyngitis, they're not well treated or treated on time, and that pharyngitis could create a cascade of events that could ultimately damage the heart valves, one of the valves, mitral valve, aortic valve, tricuspid valve, one of them could be damaged. Because of that, kids are exposed to this special risk as they grow into adulthood, or while even they were kids. Those damaged valves could form clots on them, or a clot could form on those damaged valves, and that could get ejected and go to the brain and cause stroke. So this, for example, is something unique, to those countries such as Ethiopia, who have not yet overcome, the issue with infectious diseases. Especially in this case, rheumatic heart disease could be a very, very sad and sometimes catastrophic complication of a simple infection. Yeah, and this plus maybe I would say cryptogenic stroke, category is slightly wider here because we cannot chase down every stroke, to the end in terms of workup, because we have to stop at some point because of availability of resources. For example, loop recorders are not available in Ethiopia. And if you talk about Holter monitoring, for example, you can only monitor the heart rhythm for up to 96 hours at a time. Actually, 48 hours. You have to order two of them back to back so they can do 48 hours, so you can get a 96 hours Holter monitor. That's as far as you can get. There's nothing beyond that. I mean, I'm told by the cardiologists, the softwares that they have cannot do Holter monitoring, for longer durations beyond 48 hours. So imagine, I mean, sometimes you diagnose atrial fibrillation a week or two or a month or even 18 months later when you do when you do long-term Holter, such as loop recorders. But you can't do that here. So those are, I think, some of the differences between here and in the US.
And that makes a lot of sense. And I don't want to take a lot of your time because I know our differences in hours are pretty big. It's pretty late over on your side. But just diving into a little bit more of the technical side, has practicing in Ethiopia changed your approach to neurointervention anyway? Specifically, like different catheter selection, use of aspiration versus stent retriever, use of DAPT or dual antiplatelet versus any kinds of drips or anything like that?
Yes, that's a great question. There's so much variability of practices, neurointerventional practices across the US. As you know, even partners, myself and Dr. Hassan, do some things differently. Even if we train together as fellows in the University of Minnesota, we came out, and throughout our years of practice, we have polished up and selected how we practiced, neuro IR in the US. So, but when you come to Ethiopia, since cost is a big problem, you try to resort to less expensive methods of doing the same thing. Because I knew I was coming to Ethiopia, for example, you asked about aspiration of blood clots from the brain. I am more adapt guy, known for that actually in South Texas, and less of a stent retriever kind of guy. Me and Amir split there, for example. He likes to go the badass sort of, I'm sorry about that, using that word, but that's what we call it, technique where we use balloon guides and lesional aspiration and also stent retrievers. But I always start with adapt technique first. And I trained myself enough over the last several years to be as good as I can with adapt techniques. That saves a lot of money. But also in other things, like for example, catheters usage. When we coil a brain aneurysm, just using a guide catheter and a microcatheter with primary coiling is an important skill to learn, instead of a guide catheter, an intermediate catheter, and then a balloon and other things. Although I love to use balloons, because balloon assisted coiling, it's good for safety, it's good for a lot of things. But cutting out a balloon could could mean cutting out $1,000, or cutting out an intermediate catheter could mean cutting out $800 to $900. So yes, in this way, we definitely shape up our practice in Africa. GTTs or drips are less available than just preparing patients with dual antiplatelet therapy for carotid stenting. But in emergencies, for example, you have a tandem lesion, tandem occlusion. What do? You try to angioplasty and leave it alone as much as you can. But rarely you would have to stent acutely. For those, I have kept a few or some supply of eptifibatide. We don't have tirofiban here, but we do have eptifibatide that I keep some with me just in case I need to use that. And the last thing is really I'm a radialist. Big time radialist. I actually pushed for our center to become involved in radial access in South Texas. We got our ultrasound bought by our hospital. I really helped a lot in bringing up and running the radial program in South Texas. So I started doing this since 2016, 17, 18. And now I do the same thing here. Why? Because closure devices are expensive, right? They add to the cost. You use femoral access, you need to use closure devices. So as much as possible, I go through the radial access, and that's helping a lot. It's safer, relatively safer, and also less expensive.
Wonderful, and makes a lot of sense. Finally, any advice that you have for future vascular neurologists or any endovascular neurologists, specifically for all of us who are starting out in our vascular neurology fellowship?
Yeah, so obviously I went to South Texas. It was an underserved area at the time when Dr. Hassan and I moved down there, and it has paid off in a huge way. I would do it again because I finished residency at George Washington University Hospital, and my chairman then, actually chairman of neurosurgery, Dr. Kapuri, told me when I moved to Minnesota for my endovascular fellowship or stroke fellowship, he told me, Wandy, once you're done, come back to GW and I will hire you, obviously. And I was excited. And I went to Minnesota with that in mind. And after I finished fellowship, of course, I went back to interview at George Washington University. And of course I was accepted because he had promised me. But then I went South Texas also. I had interviewed in South Texas within 3 months of Amir's arrival. Basically, he started his practice in July, and I was already interviewing in September because I'm a year behind him. And I decided to stick with South Texas because I wanted to be part of a program that's being built from the bottom up. I learned a lot of things about building a program. I learned about cost effectiveness or being cost conscious. And since I always have Ethiopia in mind, I also there's also a lot of similarities as we discussed between Ethiopia and here. So I learned those things, and very, very happy to be part of a program that was being built from the bottom up. So my advice for the young people or those who are graduating is they should consider serving in underserved areas. Definitely it can be challenging, but ultimately it's more fun and very fulfilling, to be very honest, very fulfilling to be part of a program that is being built from the bottom up. So be bold and have some courage and be courageous rather, but also be careful and plan ahead. If you do plan ahead, because I planned my Ethiopian trip for nearly 6 to 7 years, and it's working well. A lot of pain and challenges with it, but saving one life is all worth it. So I just tell them that go ahead and do it. So
Dr. Tekle, you might want to trademark that phrase, be bold.
yeah.
Could be the future future inspiration for all of us. But anyway, I'd like to thank you so much for taking time off your schedule. We're all rooting for you in Ethiopia. And then hopefully someday I'll get to scrub in with you for some case and then get a good cup of great Ethiopian coffee.
Oh, absolutely, yes. Ethiopia introduced coffee to the world. You know that, right?
Absolutely.
So we have, the coffee Arabica, which is awesome. I'd love to definitely serve you a few cups, and definitely would love to have you either here in Ethiopia or also in South Texas in our cat labs. Thank you so much for having me.
Thank you so much, Dr. Tekle. You have a good night.
Thank you.
And that's it for this episode of Stroke Busters. As always, ideas and opinions expressed on this podcast are our own and are not a substitute for expert medical advice. Always contact your doctor before starting any program or therapy to make sure you are getting the best care tailored to your unique situation. UT Health Stroke is on social media. Follow us on Twitter, LinkedIn, Instagram, and Facebook at UT Health Stroke to stay updated on upcoming episodes, share with colleagues, friends, and family. For updates and the latest news on the Stroke Institute, go online to uth.edu/stroke-institute. Until next time, take care.